We're going to look at diabetes, chapter 53. The most important thing that I can tell you at this point is to please look up the terminology so that you are familiar with the dialogue that is occurring throughout the chapter. So we'll be looking at pathophysiology, the manifestation, complications, and management of diabetes or diabetes mellitus. There are potential long-term complications from diabetes, and of course, this makes it very challenging as a disease. It is associated with adult blindness, end-stage renal disease, and non-traumatic lower limb amputation. So diabetes mellitus. It is a chronic multi-system disease characterized by hyperglycemia from abnormal insulin production, impaired insulin use, or both. It is prevalent and growing as a health problem throughout the world. In the United States, an estimated 34.2 million people, or 10.5% of the population, have diabetes mellitus. The etiology and the pathophysiology. Before we move on, it is the 7 leading cause of death. Current theories link the cause of diabetes mellitus singly or in combination to genetic, autoimmune, and environmental factors like viruses, higher weight. Regardless of its cause, it is mainly a disorder of glucose metabolism related to absent or insufficient insulin supply and or ineffective use of available insulin. The American Diabetic Association recognizes 4 different classes of diabetes mellitus. The 2 most common are type 1 and type 2. And then another type is maturity onset diabetes of the young. The 2 other classes are gestational diabetes and specific types of diabetes with various causes. You will see a table 53.1 for comparisons of diabetes 1 and type 2, where you look at factors, like the age of onset, the type of onset, the prevalence, the environmental factors, the primary defect, and the islets, cells, antibodies. So take some time and preview that to help with your comprehension. There's 2 pages of that, slide 5 and slide 6. So we go on to etiology and pathophysiology, looking at the normal glucose and insulin metabolism. Insulin is a hormone made by the beta cells or the B cells in the islets of Langerhans of the pancreas. Under normal conditions, the pancreas continually releases insulin into the bloodstream in small amounts. Release increases when we ingest food, and that's where you go back and look at figure 53.1. Insulin lowers glucose and facilitates a stable normal glucose range of about 74 to 106 milligrams per deciliter. The amount of insulin secreted daily by an adult is about 40 to 50 units, or 0.6 units per kilogram of body weight. Insulin promotes glucose transport from the bloodstream across the cell membrane to the cytoplasms of the cell. So look at this slide, slide 8, that looks at the normal insulin secretion over a span of time from 4 a.m. to midnight. And you will review and study that. The plasma insulin is going up on the left side. You see that we have 25, 50, 75 units per milliliter. So according to how we eat, we get up, we are at a base level, and then we eat breakfast at spikes, and the body produces the insulin that we need, about 25 units or so. Then we eat lunch, and then it's producing about 40, close to 50, and then we have a break with that, and then at dinner time we get another spike after we're eating. So we're looking at insulin. So insulin now, as I started to say, promotes glucose transport from the bloodstream across the cell membrane to the cytoplasm of the cell. It breaks down glucose to make energy. Liver and muscle cells store excess glucose as glycogen. Insulin inhibits gluconeogenesis, enhances fat depositions, and increases protein synthesis. Decreased insulin, there's a release. When we have a lower level of insulin or decrease in insulin, there's a release of stored glucose from the liver and protein from muscle and fat from adipose tissue. So remember that the cells now break down glucose to make energy. So the liver and the muscle cells will store excess glucose as glycogen. There's a rise in plasma insulin after a meal, and that inhibits or blocks gluconeogenesis. There's an enhancement of fat deposition of adipose tissue, increased protein synthesis. For this reason, insulin is an anabolic or storage hormone. The fall in insulin levels during normal overnight fasting promotes the release of stored glucose from the liver, protein from the muscle, and fat from adipose tissue. So your skeletal muscle now and adipose tissues have specific receptors for insulin and are considered insulin-dependent tissues. We look at slide 10, and it gives us an idea of what's happening there. Let's go on over to skeletal muscles and adipose tissues, where I started, have receptors for insulin. They are insulin dependent. Insulin is required to unlock receptor sites, allowing the transport of glucose into the cells to be used for energy. Other tissues, for example, your brain, your liver, your blood cells, do not directly depend on insulin for glucose transport, but require an adequate glucose supply for normal functioning. Although liver cells are not insulin-dependent tissue, insulin receptor sites on the liver facilitate uptake of glucose and its conversion to glycogen. We have a counter-regulatory mechanism in place. Let's talk about the counter-regulatory hormones. So other hormones like glucagon, epinephrine, growth hormone, cortisol work against the effects of insulin. They are called our counter-regulatory hormones. These hormones increase glucose levels, stimulate glucose production and release by the liver, and decrease the movement of glucose into the cells. The counter-regulatory hormones and insulin work together to maintain glucose levels within the normal range by regulating the release of glucose for energy during food intake and the periods of fasting. Insulin is synthesized from its precursor, proinsulin. Enzyme splits proinsulin to form insulin and C-peptide. The two substances are released in equal amounts. Therefore, measuring C-peptide in serum and urine is a useful indicator of pancreatic B-cell function and insulin levels. So that's what, just having gone through that on slide 13. So we will move on to slide 14. And we'll look at type 1 diabetes mellitus. Type 1 diabetes accounts for 5 to 10% of all people with diabetes mellitus. Type 1 generally affects people under 40 years of age, although it can occur at any age. And so we look at it in terms of the etiology and the pathophysiology. Type 1 diabetes is an autoimmune disorder in which the body develops antibodies against insulin and or pancreatic B cells that make insulin. This eventually results in not enough insulin for a person to survive. A genetic predisposition and exposure to a virus or factors that may contribute to developing immune-related type 1 diabetes mellitus. So for this, you will look at box 53.1. So as we're looking now at our slide, which is helping us with this, genetic link, there's genetic predisposition, the HLAs, and exposure to virus, as I said prior, that contribute to immune-related type 1 diabetes. Look at the genetics in the clinical practice box. They're idiopathic diabetes, it's inherited, latent autoimmune diabetes in adults, LADA, slow progressive type 1 diabetes. We look at the onset of the disease. In type 1 diabetes, the islet cell autoantibodies responsible for B cell destruction are present for months to years before the onset of symptoms. Manifestations develop when the person's pancreas can no longer make enough insulin to maintain normal glucose. Once this occurs, the onset of symptoms is usually rapid. Patients often present with impending or actual ketoacidosis. The patient usually has a history of recent sudden weight loss, and the classic symptoms are polydipsia, excessive thirst, polyuria, frequent urination, and polyphagia, excessive hunger. The person with type 1 diabetes mellitus requires insulin from an outside source that's called exogenous insulin to sustain life. Without insulin, the patient would develop diabetes-related ketoacidosis, or what we call DKA, a life-threatening condition causing metabolic acidosis. Newly diagnosed patients may have a remission or honeymoon period for 3 to 12 months after starting treatment. During this time, the patient needs little injected insulin because the B-cell insulin production is still sufficient for healthy glucose levels. Eventually, as the cells are destroyed, the glucose levels increase, the honeymoon period ends, the patient then requires insulin on a permanent basis. We're looking at type 2 diabetes mellitus. It accounts for 90 to 95% of people with diabetes. Many factors contribute to developing it. These include having a family history, being overweight or obese, and being older. Although it occurs less often in children, the incidence is increasing due to increasing prevalence of childhood obesity. Type 2 diabetes mellitus is more prevalent in some ethnic population. You can review box 53.2 to follow up on that information. This increase is related to genetic predisposition, environmental factors, and diet choices. And as it is said, there is greater prevalence in certain ethnic groups. When you look at the etiology and the pathophysiology, we're still talking about type 2 diabetes. It is characterized by a combination of inadequate insulin secretion and insulin resistance. The pancreas usually makes some endogenous, that's self-made insulin. However, the body either does not make enough, does not use it effectively, or both. The presence of endogenous insulin is a major distinction between type 1 and type 2. In type 1, there is the absence of endogenous insulin altogether. When we talk about that genetic link, we do not fully understand the genetics of type 2. It is likely that multiple genes are involved. We have found genetic mutations that lead to insulin resistance and a high risk for obesity in many people with type 2. Persons with first-degree relatives with the disease are 10 times more likely to develop type 2. Metabolic abnormalities have a role in developing type 2 diabetes mellitus. The first factor is insulin resistance. This is a condition in which the body tissue do not respond to the action of insulin because insulin receptors are unresponsive, insufficient in number, or both. Most insulin receptors are located on skeletal muscle fat and liver cells. When insulin is not properly used, the entry of glucose into the cell is impeded, causing hyperglycemia. In the early stages of insulin resistance, the pancreas responds to high glucose levels by producing more insulin if the beta cell function is normal. This creates a temporary state of hyperinsulinemia that coexists with hyperglycemia. A second factor in developing type 2 is a marked decrease in the ability of the pancreas to make insulin. The beta cells become fatigued from the compensatory overproduction of insulin or when B cell mass is lost. We do not know the reason the B cell fails to adapt. It may be due to the adverse effects of chronic hyperglycemia or high circulating free fatty acids. In addition, the alpha cells of the pancreas increase production of glucagon. So this leads to a third factor, which is inappropriate glucose production by the liver. Instead of properly regulating the release of glucose in response to blood level, the liver does so in a haphazard way that does not respond to the body's need at the time. A fourth factor is the production of hormones and cytokines at disposed tissue. Adipokines secreted by adipose tissues appear to play a role in glucose and fat metabolism. They are likely to contribute to developing type 2 diabetes. We think adipokines cause chronic inflammation, a factor involved in insulin resistance, type 2 diabetes mellitus, and cardiovascular disease. The two main adipokines thought to affect insulin sensitivity are adiponectin and leptin. Finally, the brain, kidneys, and the gut have roles in developing type 2 diabetes mellitus. We are continuously learning more about the metabolic factors in developing type 2 diabetes. People with metabolic syndrome have an increased risk of developing type 2 diabetes. You have a comparative figure 53.3, altered mechanisms in type 1 and type 2 diabetes. We're going on to talk a little bit about metabolic syndrome. As we said, that people with metabolic syndrome have an increased risk of developing type 2 diabetes. Metabolic syndrome has 5 components: increased glucose levels, abdominal obesity, high blood pressure, high triglyceride levels, and decreased high-density lipoproteins or HDL levels. A person with 3 of the 5 components is considered to have metabolic syndrome. Overweight persons with metabolic syndrome can reduce their risk for diabetes through food choices and regular physical activity. Onset of the disease. The disease onset in type 2 is usually gradual. The person may go for many years with undetected hyperglycemia and few, if any, symptoms. Many people are diagnosed in routine laboratory testing when they undergo treatment for other conditions or they have high glucose or glycosylated hemoglobin A1C levels. The signs and symptoms of hyperglycemia develop when 50 to 80% of the B cells are no longer secreting insulin. At the time of diagnosis, the average person has had diabetes type 2 for 6.5 years. When we talk about prediabetes, persons diagnosed with prediabetes are at increased risk for developing type 2. It is defined as impaired glucose tolerance, IGT, impaired fasting glucose, IFG, or both. It is an intermediate stage between normal glucose homeostasis and diabetes mellitus. Glucose levels are high, but not high enough to meet the diagnostic criteria for diabetes. A diagnosis of IGT is made if the 2-hour oral glucose tolerance test, OGTT, values 140 to 199. IFG is diagnosed when fasting glucose levels are 100 to 125. Persons with prediabetes usually do not have symptoms. However, long-term damage to the body, especially the heart and blood vessels, may already be occurring. It's important for people to undergo screening and undertake risk factors for diabetes mellitus. People with prediabetes can take action to prevent or delay their developing type 2 diabetes. So we are to encourage those with prediabetes to have their glucose levels and A1C checked regularly, monitor for signs such as fatigue or frequent infections, maintaining a healthy weight, exercising regularly, and making healthy food choices will reduce the risk for developing type 2 diabetes. And as we have said, when we talk about prediabetes, and we're on slide 24, they may be asymptomatic for a long period, but the damage may already be occurring, especially to the heart and blood vessels. So we do a lot of teaching, as I just said in the previous slide. Undergo the screening, the glucose and the A1C, learn to manage their risk factors. They are to monitor for signs of diabetes and maintain healthy weight, exercise, and make healthy food choices. We're now going to take a look at gestational diabetes. It develops during pregnancies and occurs about 2 to 10% of pregnancies in the U.S. Women with gestational diabetes have a higher risk for cesarean delivery. Their babies are at risk for perinatal death, birth injury, and neonatal complication. Women who are at high risk for gestational diabetes are screened at the first prenatal visit. Those at high risk include women who are obese, are of advanced maternal age, or have a family history of diabetes mellitus. We screen women with an average risk for gestational diabetes using OGTT at 24 to 28 weeks of gestation. Most women with gestational diabetes have normal glucose levels within 6 months postpartum. Women with a history of gestational diabetes have up to 63% chance of developing type 2 diabetes within 16 years. There are other specific types of diabetes. Diabetes occurs in some people because of another medical condition or treatment of a medical condition, and that causes abnormal glucose levels. Conditions that may cause it can result from injury to, interference with, or destruction of the beta cell function in the pancreas. These would include Cushing's syndrome, hyperthyroidism, pancreatitis, cystic fibrosis, hemochromatosis, and parenteral nutrition. Common drugs that can induce diabetes include corticosteroids like prednisone, thiazides, phenetons, dilantin, atypical antipsychotics like clozapine or clozaril. Diabetes caused by medical condition or drugs can resolve when the underlying condition is treated or the drug is discontinued. What are the classical symptoms? Everybody knows the polyuria, polydipsia, and polyphagia. Polyuria meaning frequent urination, polydipsia, excessive thirst, polyphagia, excessive hunger. Some of the other problems that occur with it is weight loss, weakness, fatigue, and ketoacidosis. The osmotic effect of excess glucose in the bloodstream causes the polydipsia and the polyuria. Polyphagia is a result of cell malnourishment when insulin deficiency prevents the cells from using glucose for energy. Weight loss may occur because the body cannot get the glucose, and instead it starts to break down fat and protein to try to make energy. Weakness and fatigue may result because the cells lack energy, the needed energy from glucose. So diabetic ketoacidosis, a complication more common in those with untreated diabetes 1, it has additional manifestations. So for the non-specific symptoms, classic symptoms of type 1 may manifest. We already said fatigue, recurrent infections, recurrent vaginal yeast or candida infections, prolonged wound healing, and vision problems can occur. And we talk about the diagnostics. The diagnostics of diabetes mellitus is made using one of four methods. Look at table 53.2. If a patient has hypoglycemic crisis or clear symptoms of hypoglycemia, the three Ps, polyuria, polydipsia, and polyphagia, with a random plasma glucose level of 200 milligrams per deciliter or greater, repeat testing is not needed. Otherwise, criteria 1 through 3 require confirmation by repeat testing to rule out laboratory error. The repeat test should be the same test used initially. For example, if a random high glucose was the initial measurement, that same measure should be used to confirm a diagnosis. The accuracy of lab results depend on patient preparation and attention to many factors that influence the results. Factors that can falsely increase values include recent severe restriction of carbohydrate intake, acute illness, drugs like contraceptives and corticosteroids, and restricted activities such as bed rest. A patient with impaired gastrointestinal absorption or who has recently taken acetaminophen may have false negative results. A1C measures the amount of glycosated hemoglobin as a percentage of total hemoglobin. For example, an A1C of 6.5% means that 6.5% of the total hemoglobin has glucose attached to it. The amount of glycosated hemoglobin depends on the glucose level. When glucose levels are high over time, the amount of glucose attached to hemoglobin increases. Thus, glucose stays attached to the red blood cell for the life of the cell, about 120 days. Therefore, A1C provides an average measure of glucose levels over the previous 2 to 3 months. Increases in the A1C reflect higher average glucose levels. A1C does not, however, consider fluctuations in glucose. It does not give a good indicator of how often someone has high or low. An advantage of the A1C includes greater convenience since fasting is not needed. Diseases affecting RBCs, for example, iron deficiency anemia, sickle cell anemia, can influence the A1C and should be considered when interpreting results. When we look at fructosamine, it reflects glycemia in the previous 1 to 3 weeks. It may show change before the A1C used by hemoglobinopathies or short-term measurements of glucose levels. There's an islet cell and auto antibody testing, and there are some other tests out there that help us to look at the situation, like our lipids, our BUN, creatinine and electrolytes, albuminuria, urine acetone, BP, EKG, eye exam, dental, foot exams, neurological, ABIs, and our weight. Please review table 53.3 when it looks at interprofessional care. The goals of diabetic management is to reduce symptoms, promote the well-being, prevent acute complications related to hyperglycemia and hypoglycemia, and to prevent or delay the onset and progression of long-term complication. These goals are most likely to be met when the patient maintains glucose levels as near to normal as possible. Meeting goals for what we refer to as the ABCs of diabetes can help patients manage diabetes and lower the risk of heart attack and stroke. The ABCs refer to A1C, blood pressure, and cholesterol. Only 12.2% of the adults meet the target goals for all three steps. Patient teaching, which enables a patient to self-manage their own care, is essential to achieve glycemic goals. Nutrition therapy, drug therapy, exercise, and blood glucose monitoring are the tools used in managing diabetes mellitus. The three major types of glucose-lowering agents are your GLAs used in diabetes treatment, or insulin oral agents, and non-insulin injectable agents. But let's get past slide 33. Patient care and caregiving teaching involves teaching on nutrition therapy, on the drug therapy, the glucose-lowering agents like insulin oral agents, non-insulin injectable agents, exercise, self-monitoring of glucose. Type 2, healthy eating, regular exercise, healthy weight may be sufficient, may need medication as the disease progresses. When we talk about drug therapy and insulin, exogenous, which is injected insulin, is needed when someone has inadequate insulin to meet specific metabolic needs. People with type 1 diabetes mellitus require exogenous insulin to survive. They often use multiple daily injections of insulin, often 4 or more, or continuous insulin infusion via an insulin pump to adequately maintain glucose level. People with type 2 may need exogenous insulin during periods of severe stress, such as illness or surgery. Since type 2 diabetes is progressive, over time the combination of nutrition, exercise, OAs, and non-insulin injectable agents may no longer adequately manage glucose levels. At that point, we add exogenous insulin to the management plan. People with type 2 may also need up to 4 injections per day to adequately maintain their glucose levels. Insulin pumps may be an option for patients with type 2 diabetes. So we're now looking at types of insulin. Today, people use genetically engineered human insulin made in laboratories. The insulin is derived from common bacteria, example E. coli, or yeast cells derived from common bacteria. Or yeast cells, using recombinant DNA technology. Types of insulin differ by their onset, peak action, and duration. They are categorized as rapid action, short acting, intermediate acting, and long acting insulins. You can review table 53.4, which is on 1291 of your book, to go through these. You have on slide 36 insulin preparations. It shows you in this chart your different classification of insulins: rapid acting, short acting, intermittent acting, and the long acting insulin. You need to learn the onset and peak and durations for your NCLEX exams. We look at insulin plans. And you look at table 53.4, it shows you examples of insulin plans. The insulin approach that most closely mimics endogenous insulin production is the basal bolus plan, often called intensive or physiological insulin therapy. It consists of multiple daily insulin injections or an insulin pump together with frequent blood glucose monitoring or continuous glucose monitoring. Injections include rapid or short-acting bolus insulin before meals and intermediate or long-acting basal background insulin once or twice a day. The goal is to achieve a glucose level as close to normal as possible as much of the time as possible. We refer to this as time in range. Other less intense plans can promote healthy glucose levels for some people. Ideally, the patient and the healthcare provider work together to choose a plan. Selection criteria are best on the desired and feasible glucose levels and the patient's lifestyle, food choices, and activity. If a less intense plan is not giving the person optimal results, the healthcare provider can encourage a more intense approach. So looking at slide number 38, as I said earlier, the patient and the healthcare provider together can choose a plan based on desired and feasible glucose levels, lifestyle, food choices, activity patterns, and less intense plans work for some people. Okay, let's look at mealtime insulin bolus. It's mealtime insulin, a bolus. To manage postprandial glucose levels, the timing of rapid and short-acting insulin in relation to meals is crucial. Rapid-acting synthetic insulin analogs, which include Aspart, and as Novolog and Fiasp, Glulisine, Ephedra, and Lispro, Humalog, have an onset of action of about 15 minutes. They should be injected within 15 minutes of eating. The rapid-acting analogs most closely mimic natural insulin secretion in response to a meal. Short-acting regular insulin has an onset action of 30 to 60 minutes. It is injected 30 to 45 minutes before a meal to ensure that insulin is working at the same time as meal absorption. Because timing an injection 30 to 45 minutes before a meal is hard for some people to do with their lifestyles, those taking insulin with their meals often prefer the flexibility of rapid-acting insulins. Short-acting insulin is more likely to cause hypoglycemia because of a longer duration of action. When we look at long or intermediate acting or basal background insulin, in addition to meal time insulin, people with diabetes 1 use a long or intermediate acting basal, which is a background insulin, to maintain glucose in between meals and overnight. Without 24-hour background insulin, people with type 1 are more prone to develop DKA. Many people with type 2 who use OAs will need basal insulin to adequately manage glucose levels. The long-acting insulins include degludec or Tresiba, Detamir or Levemir, and Glargine, Lantus, Toujeo, or Basaglar, or Basaglar. Long-acting insulin is released steadily and continuously for most people. It does not have a peak action. The action time for long-acting insulin varies, although they can be given once daily. Detamir is often given twice daily. Because they lack peak action time, the risk of hypoglycemia with this type of insulin is greatly reduced. Glargine, which is Lantus, Toujeo or Toujeo, and Basaglar, and Detamir must not be diluted or mixed with any other insulin or solution in the same syringe. That's an important point for you to remember. Glargine, okay, which would be Lantus, Toujeo, or Basaglar must not be diluted or mixed with any other insulin or solution in the same syringe. If OAs and long-acting insulins are not adequate to achieve glycemic goals, people with type 2 diabetes mellitus may need to add mealtime insulin. Intermediate acting insulins like NPH can be used as basal insulin. It has a duration of 12 to 18 hours. The disadvantage of NPH is that its actions peak 4 to 12 hours after injection, which can result in hypoglycemia. NPH can be mixed with short and rapid-acting insulins. It is never given IV. Okay, so let's review this on slide 41. Intermittent intermediate acting insulin, NPH, duration 12 to 18 hours, peak 4 to 12. You can mix it with short and rapid acting insulins, and it is never given IV. Please remember these for your NCLEX. Then we have combination insulin therapy. For those who want to use only 1 or 2 injections per day, a shorter rapid-acting insulin is mixed with intermediate-acting insulin in the same syringe. This allows a person to have both mealtime and basal coverage without having to give 2 separate injections. Although this may be more appealing, most people achieve target glucose level with the basal bolus therapy. Patients may mix the 2 types of insulin themselves or use a commercially pre-mixed formula or pen. Pre-mixed formulas offer convenience as people do not have to draw up and mix insulin from 2 different vials. This is helpful to those who like the visual, manual, or cognitive skills to mix insulin themselves. However, it is harder to achieve target glucose levels because there's less opportunity for flexible dosing based on needs. Now we talk about insulin storage. As a protein, insulin has a special storage consideration. Extreme temperatures alter insulin and can make it less effective. Insulin vials and pens in use may be left at room temperature for up to 4 weeks. The room temperature cannot be higher than 86 degrees Fahrenheit or below freezing 32 degrees. Teach patients to avoid exposing their insulins to direct light. A person who is traveling in hot climates may store insulin in thermos or coolers to keep it cool, not frozen. Store unopened insulin vials and pens in the refrigerator. People who are traveling or caregivers of patients with impaired vision or who cannot fill their own syringes may pre-fill insulin syringes. Pre-filled syringes with 2 different insulins are stable for up to 1 week when stored in the refrigerator. Syringes with only 1 type of insulin are stable for up to 30 days. Teach patients to store syringes in a vertical position with the needle pointed up to avoid clumping of suspended insulin in the needle. Before injection, gently roll pre-filled syringes between the palms 10 to 20 times to warm and resuspend the particles. Some insulin combinations cannot be pre-filled and stored because the mixture can alter the onset action or the peak times of either insulin. Consult a reference as needed when mixing and pre-filling different types of insulin. We're now going to look at insulin administration. Routing doses of insulins are given by subcutaneous injection. Regular insulin can be given IV when intermediate onset of action is desired. Insulin is not taken orally because it is inactivated by gastric fluids. Teach patients to avoid injecting insulin IM because rapid and unpredictable absorption could result in hypoglycemia. When we talk about insulin injections, the steps in giving a subcutaneous injection are outlined in your table 53.6. Teach this technique to new insulin users and review it periodically with long-term users. Never assume that because a person already uses insulin, they know and practice the correct injection technique. The patient may not have understood prior instruction, or changes in eyesight might result in incorrect preparation. The patient may not see air bubbles in the syringe, or may improperly read the scale on the syringe. The patient receiving mixed insulins in the same syringe needs to learn the right technique for combining them if they are not using commercially prepared premix. The speed with which peak serum concentrations are reached varies with the injection sites. The fastest subcutaneous absorption is from the abdomen, followed by the arm, the thigh, and the buttock. Although the abdomen is often the preferred injection site, other sites work well. Caution the patient about injection into a site that will be exercised. For example, injecting into the thigh and then going jogging could increase body heat and circulation. This could increase the rate of absorption and speed the onset of action, causing hypoglycemia. Teach the patient to rotate the injection sites within and between the site. This allows for better insulin absorption. It may be helpful to think of the abdomen as a checkerboard, with each 1/2 inch square representing an injection site. Injections are rotated systematically across the board, with each injection site at least 1/2 to 1 inch away from the previous. It can be helpful to inject fast-acting insulin into faster absorbing sites and slow-acting insulin into slower absorbing sites. So you see on slide 45 the injection sites for insulin that can be used. Most commercial insulin is available as U100. This means that 1 milliliter contains 100 units of insulin. U100 insulin must be used with the U100 marked syringe. Disposable plastic insulin syringes are available in a variety of sizes, including 1, 5, and 0.3 milliliters. The 0.5 milliliter size is for doses of 50 units. The 0.3 for doses 30 units. The 0.5 minus and 0.3 milliliter syringes are in 1 unit increments. This provides more accurate delivery when the dose is an odd number. The 1.0 milliliter syringe is necessary for patients who inject more than 50 units. The 1.0 milliliter syringe is in 2 unit increments. When patients change from 0.3 or 0.5 to a 1.0, tell them of the dose increment differences. Insulin syringe needles come in 3 lengths: 5 millimeters, 8 millimeters, and 12.7 millimeters. Needle gauges vary among syringes. The needle gauges available 28, 29, 30, and 31. The higher the gauge number, the smaller the diameter. This results in a more comfortable injection. Only the person using the syringe should recap it. Patients performing self-injection can prepare the site with routine hygiene, such as washing with soap and rinsing with water. Okay, we have gone through much of what's on page 47. Only user recap syringes, no alcohol swabs, wash with soap and water. In hospitals, follow policy to cleanse site. With the insulin pen, it is portable, convenient, compact, discreet, various lengths and gauges, good option for patients with decreased vision, Patient education and printed instructions should be given. You see a picture of an insulin pen on slide 48. There's a needle cap. It comes off. The insulin is in the cartridge. You set the dial to how much on the plunger end, how much you want to give. The numbers show up in a window. And now we'll talk about the insulin pump. An insulin pump delivers a continuous subcutaneous insulin infusion through a small device worn on a belt, in a pocket, or under clothing. The pumps use rapid-acting insulin. It's located into, it is loaded into a reservoir or cartridge and connected via plastic tubing to a catheter inserted into the subcutaneous tissue. Insulet Corporation has an insulin pump that is tubing free. All insulin pumps are programmed to deliver continuous infusion of rapid-acting insulin 24 hours a day. This is known as a basal rate. Basal insulin can be temporarily increased or decreased based on carbohydrate intake, activity, or illness. Pump users need different basal rates at different times of the day. At mealtime, the user programs a pump to deliver a bolus infusion of insulin appropriate to the amount of carbs ingested and an additional amount if needed to bring down or correct high preprandial glucose. The infusion set is changed every 2 to 3 days and placed in a new site to avoid infection and promote good insulin absorption. Insulin pump users check their glucose levels at least 4 times a day, and they use a continuous glucose monitoring system. Monitoring 8 times or more per day is common. And you see a picture of the Omnipod insulin management system. We've already talked about the insulin pump, the advantages and the potential concerns about it. Problems with insulin therapy is associated with hypoglycemia, allergic reactions, lipodystrophies, and the Somogyi effect. Hypoglycemia will be discussed later, but let's look at allergic reactions here for just a minute. Local inflammatory reactions to insulins may occur. These include itching, redness, and burning around the injection site. Local reactions may be self-limiting within 1 to 3 months or may improve with a low dose of antihistamines. A true insulin allergy is rare. It is manifested by a systemic response with urticaria and possibly anaphylactic shock. Preservatives in the insulin and the latex or rubber stoppers on the valves have caused allergic reactions. Then we have lipodystrophy. Let me go through this slide 52. We do an assessment of patients treated with glucose lowering agents, newly diagnosed, or reevaluation of regime, cognitive, psychomotor, affective. We need to evaluate these behaviors. Follow up if we need, look at the effectiveness of the therapy, side effects of the therapy, and self-management behaviors. So we had started talking about problems with insulin therapy. Hypoglycemia is a primary problem. We'll discuss that later, but again, we're going to go back now and look at allergic reactions. Local inflammatory reactions to insulin may occur, but they are rare. They include itching, redness, and burning around the injection site. They may be self-limiting with 1 to 3 months, or they may improve with a low dose of antihistamines. A true insulin allergy is, as I said, is rare. It is manifested by a systemic response with urticaria and possibly anaphylactic shock. Preservatives in the insulin and latex or rubber stoppers on the valve have caused allergic reactions. Lipodystrophy, changes in the subcutaneous fatty tissue, may occur if the same injection sites are used frequently. Atrophy, which is uncommon, is a wasting of subcutaneous tissue. It presents in indentations in the injection sites. Hypertrophy happens more often and is a thickening of the subcutaneous tissue. It eventually regresses if the person does not use the site for at least 6 months. Injecting into a hypertrophied site may cause erratic insulin absorption. Then we look at the Somogyi effect and Don phenomenon. Hyperglycemia in the morning may be due to Somogyi effect. A high dose of insulin causes a decline in glucose levels during the night. As a result, counter-regulatory hormones like glucagon, epinephrine, growth hormone, cortisol are released. They stimulate lipolysis, gluconeogenesis, and glycogenolysis, which in turn cause rebound hyperglycemia. The danger of this effect is that when glucose levels are measured in the morning, hyperglycemia is present and the patient or the healthcare provider may increase the insulin dose. If a patient has morning hyperglycemia, checking glucose levels between 2 and 4 for hyperglycemia will help determine if the cause is the Somogyi effect. The patient may report headaches on awakening and recall having night sweats or nightmares. The dawn phenomena is also characterized by hypoglycemia. A look at this treatment is a bedtime snack, reducing the dose of insulin, or both. The dawn phenomena we go on to look at is also characterized by hyperglycemia that is present on awakening. Two counter-regulatory hormones, growth and cortisol, which are excreted in increased amounts in the early morning hours, may be the cause of this phenomenon. The dawn phenomena affects many people with diabetes mellitus. It tends to be most severe when growth hormone is at its peak in adolescence and young adulthood. Careful assessment is needed to diagnose the Somogyi effect or dawn phenomena because the treatment for each differs. The treatment for the Somogyi is a bedtime snack, reducing the dose of insulin, or both. The treatment for dawn phenomena is an increase in insulin or an adjustment in administration time. Your assessment must include insulin dose, injection sites, and variability in the time of meals or insulin administration. Ask the patient to measure and document bedtime, nighttime between 2 a.m. and 4 a.m. and morning fasting glucose levels on several occasions. If the pre-dawn levels are less than 60 and signs or symptoms of hypoglycemia are present, the insulin dose should be reduced. If the 2 a.m., 4 a.m. dose is high, the insulin dosage should be increased. Counsel the patient on appropriate bedtime snacks. Let's look at inhaled insulin, or Afrezza. Afrezza is a rapid-acting inhaled insulin. It is given at the beginning of each meal or within 20 minutes after starting a meal. It must be used in combination with long-acting insulin in those with type 1 diabetes. It should not be used to treat diabetic ketoacidosis. People with chronic lung disease such as asthma, COPD, or those who smoke should not use Afrezza because bronchospasms can occur. Other side effects include hypoglycemia, cough, and throat pain or irritation. So when we talk about drug therapy Oral and non-insulin injectables agents. OAs and non-insulin injectable agents work to improve the mechanisms by which the body makes and uses insulin and glucose. These drugs primarily work on three defects of type 2 diabetes mellitus: insulin resistance, decreased insulin production, and increased liver glucose production. Review Table 53.8. They may be used in combination with drugs from other classes or with insulin to achieve glucose goals. OAs and non-insulin injectable agents. So you look at the figure 53.8, sites and mechanisms and actions of type 2 diabetes drugs. So review that. Biguanide. The most commonly used OA is metformin. It is the only drug in the biguanide class available in the United States. Metformin is the most effective first-line treatment for type 2 diabetes. Forms of metformin include glucophage, immediate release, glucophage XR, extended release, Fortamet, extended release, and Riomet, liquid. The primary action is to reduce glucose production by the liver. It enhances insulin sensitivity at the tissue level and improves glucose transport into the cells. It has beneficial effects on lipid levels. Because it may cause moderate weight loss, it may be useful for people with type 2 and pre-diabetes who are overweight or obese. It may prevent type 2 diabetes in those with pre-diabetes who are younger than age 60 and have high risk factors like hypertension, or they have a history of gestational diabetes. The patients who are having surgery or radiological procedures that involve the use of contrast media need to temporarily discontinue metformin before surgery or the procedure. This reduces the risk of contrast-induced kidney injury. And we go and look at chapter 39 to review that. They should not resume the metformin until 48 hours afterwards once the serum creatinine has been checked and is normal. Look at your oral agents, OAs, and non-insulin injectable agents when you look at table 53.8 on page 1297. The majority of your meds are there and goes over to 1298. Please make sure you adhere and review the drug alert for metformin. Do not use in patients with kidney disease, liver disease, or heart failure. Lactic acidosis is rare complications of metformin accumulation. IV contrast media that contain iodine pose a risk for CIN, which could worsen metformin-induced lactic acidosis. To reduce risk for CIN, discontinue metformin 2 days before. It can be resumed 48 hours after the procedure, assuming the kidney function is normal. Do not use in people who drink excessive amounts of alcohol. And look at the sulfonylureas. Include glimepiride, Amaryl, glipizide, glucotrol, glucotrol XL, and glyburide, which is diabeta and glinase. Their primary action is to increase insulin production by the pancreas. This makes hypoglycemia a major side effect. Meglutinides, like sulfonylureas, naticlonide, and repaglinide increase insulin production by the pancreas. However, because they are more rapidly absorbed and eliminated than sulfonylureas, they are less likely to cause hypoglycemia. When taken just before meals, pancreatic insulin production increases during and after the meal, mimicking the normal response to eating. So other examples that we know from meglitinides, Prandin, and Starlix. The alpha glucosidase inhibitors. These drugs are known as starch blockers. They work by slowing down carbohydrate absorption in the small intestine. Arcabuz and Miglitol, which is Glycet, are the available drugs in this class. They are most effective in lowering postprandial glucose. Their effectiveness is measured by checking 2-hour postprandial glucose levels. The thiazolidinenones, thiazolidinediones, sometimes called insulin sensitizers, include pioglitazone or Actos, resiglitazone or Avanzia. They are most effective for people who have insulin resistance. These drugs improve insulin sensitivity, transport, and use at target tissue. Because they do not increase insulin production, they do not cause hypoglycemia when used. These drugs are rarely used because of their adverse effects. Rosiglitazone can cause cardiovascular events like an MI. It can be obtained only through restricted access programs. It can worsen heart failure. Use is associated with increased risk for bladder cancer. When we look at dipeptidyl peptidase 4 inhibitors, normally the intestines release incretin hormones throughout the day. When glucose levels are normal or high, incretins increase insulin synthesis and release from the pancreas and decrease liver glucose production. Incretin levels increase after a meal. The two main incretin hormones are gastric inhibitory peptide, or GIP, and glucagon-like peptide, GLP-1, GLP. They are quickly inactivated by the enzyme dipeptidyl peptidase 4. DPP-4 inhibitors, also called gliptins, come in pill form. They include alogliptin or Nesema, linagliptin or Trahenta, sexagliptin or Onglyza, and sitagliptin or Januvia. DPP-4 inhibitors block the action of DPP-4, which inactivates incretin hormones. The result is an increase in insulin release, a decrease in glucagon secretion, and a decrease in liver glucose function. Since the DPP-4 inhibitors are glucose dependent, they have a lower potential for hypoglycemia. The main effect over other drugs with similar effects is the absence of weight gain as a side effect. When we look at sodium glucose transporter 2, SGLT-Z inhibitors. Normally, sodium glucose transporters reabsorb glucose from the kidneys back into the bloodstream. SGLT2 inhibitors work by blocking glucose reabsorption by the kidneys, increasing urinary glucose excretion. Drugs in this case include canagliflozin and Volcana, dapagliflozin for zesia, and empagliflozin, Jardiance. Dopamine receptor agonist is a dopamine receptor agonist, bromocriptine cycloset is a dopamine receptor agonist that improves glucose level. The mechanism of action is unknown. We think people with type 2 diabetes have low dopamine levels in the morning. These low levels may interfere with their body's ability to control glucose. Bromocriptine increases dopamine receptor activity. It can be used alone or with another type of type 2 diabetes treatment. Combination oral therapy. Many combination drugs are currently available. These drugs combine different classes of DM medications in one pill. An advantage of combination therapy is that patient takes fewer pills, thus making it easier to take medication. Glucagon-like peptide 1 receptor agonist. GLP-1 receptor agonists stimulate GLP-1, an incretin hormone. It is decreased in people with type 2 diabetes. These drugs increase insulin synthesis and release from the pancreas. They inhibit glucagon secretion. They slow gastric emptying and reduce food intake by increasing satiety. They may be used alone or with another type 2 diabetes treatment when OAs have not achieved optimal glucose level. Excerpts for semaglutide, Rybelsus, which is given early. They are all given using subcutaneous injections in a prefilled syringe. Exenatide, Byetta, is given twice daily. Liraglutide, Victoza, is given once daily. Albiglutide, Tanzium, dulaglutide, Trulicity, and exenatide, extended release, Bydureon, are given once every 7 days. So I just went through these glucagon-like peptide ones already. So you'll read up on these, the names of them specifically. Amylin analogs. Pramlintide, Semlin, is the only available amylin analog. Amylin is a hormone secreted by the beta cells of the pancreas in response to food intake. It slows gastric emptying, reduces glucagon secretion, and increases satiety. People with type 1 or 2 with high glucose levels on insulin therapy take pramlintide with their mealtime insulin. It is only used concurrently with insulin and is not replacement for insulin. The drug cannot be mixed in the same syringe with insulin. The concurrent use of pramlintide and insulin increases the risk for severe hypoglycemia during the 3 hours after injection, especially in those with type 1. Teach patients who eat a meal with at least 250 calories and fast-acting glucose on hand in case of hypoglycemia. When using pramlintide, the bolus insulin dose should be reduced. Other drugs affecting glucose levels. Both the patient and the HCP must be aware of drug interactions that can potentiate hypoglycemia, and hyperglycemia. For example, beta-adrenergic blockers can mask symptoms of hypoglycemia and prolong hypoglycemic effects of insulin. Loop diuretics can worsen hypoglycemia by inducing potassium loss. So when we talk about nutrition therapy, patient-centered nutrition therapy consisting of counseling, education, and ongoing monitoring is a cornerstone of care for people with diabetes and prediabetes. Changing eating habits can be challenging. Achieving nutrition goals requires coordinated team effort that considers a person's behavioral, cognitive, socioeconomic, cultural, and religious backgrounds and preference. Because of these complexities, a dietitian with expert in diabetes management should work with the person with diabetes. The dietitian starts with a nutrition assessment and develops a patient-centered food plan. Other team members may include nurses, certified diabetes care, education specialists, clinical nurse specialists, and social workers and other HCPs. We follow the ADA guidelines, and they state that within the context of an overall healthy eating plan, a person with diabetes can eat the same foods as a person without diabetes. That means that the same principles of healthy nutrition that apply to the general population applies to the person with diabetes. Table 53.9 describes nutrition guidelines. That's on page 1300 for people with diabetes. According to the ADA, the overall goal of nutrition is to help people make healthy food choices that will lead to achieving and maintaining safe and healthy glucose levels. And these additional goals include maintaining the levels as close to normal as safely possible to prevent or reduce the risk of diabetes-related complication, achieve lipid profiles and blood pressure levels that reduce the risk for CVD, prevent or slow the rate of development of chronic complications by modifying nutrient intake and lifestyle, address nutrition needs while considering personal and cultural preferences and respecting the person's willingness or ability to change eating and dietary habits, maintain the pleasure of eating by encouraging a variety of healthy food choices. When we talk about type 1 diabetes, people with type 1 base their meal planning on usual food intake and preferences, balanced with insulin and exercise patterns. The patient coordinates insulin dosing with eating habits and activity in mind. Day-to-day consistency and timing and amount of food eating makes it much easier to manage glucose levels, especially for those who are using conventional fixed insulin plans. Those using rapid-acting insulin can adjust the dose before each meal based on the current glucose level and the carbohydrate content of the meal. Intensified insulin therapy, such as multiple daily injections or the use of a pump, allows considerable flexibility in food selection and can be adjusted for changes from usual eating and exercise habit. This does not diminish or replace the need for healthy food choices and a well-balanced diet. Type 2 diabetes, we're talking about nutrition therapy, emphasizes achieving glucose, lipid, and BP goals. Modest weight loss may improve insulin sensitivity. Therefore, weight loss is recommended for all persons who are overweight or obese. There is no one proven strategy or method. Nutritionally adequate meal plan with appropriate serving size, a reduction in saturated and trans fat, lower carbohydrate can calorie consumption. Spacing meals is another strategy that spreads nutrient intake throughout the day. A weight loss of 5 to 7% often improves glucose level even if desirable weight is not achieved. Weight loss is best achieved by moderate decrease in calories and regular exercise. Adopting new behaviors and attitude can promote long-term health behavior changes. Monitoring glucose levels, A1C, lipids, and BP gives feedback on how well the goals of nutritional management are being met. We talk about food consumption. A healthy balance of nutrients is essential to maintain glucose levels and overall health. We teach the patient to outline their meal plan with their lifestyle and health goals in mind. There's no special eating plan for people with diabetes. The person can work with their HCP to determine which plan works best for them. Keeping in mind portions and effects on glucose, lipids, and BP. Our plans are individualized to lifestyle and health goals. We talk about carbohydrates. They're an important source of energy, fiber, vitamins, and mineral. They are needed by all people. Foods containing carbohydrates from a whole grain, fruits, vegetables, low-fat dairy are part of a healthy meal plan. The ADA recommends individualizing carbohydrate intake as there is no ideal amount for all people with diabetes. All persons benefit from including dietary fiber as a part of a healthy meal plan. The current recommendation for people with is to consume a minimum of 14 grams of fiber for 1,000 kilocalories. Nutritive and non-nutritive sweeteners may be included in a healthy meal plan in moderation. Non-nutritive sweeteners include sugar substitutes, saccharin, aspartame, sucralose, stevia, neotame, and acesulfame K. Fat. Fat provides energy, transports fat-soluble vitamins, and provides essential fatty acids. The ADA recommends 20 to 35% of total calorie intake from fat. People with diabetes benefit from eating fewer carbohydrate foods that are higher in total fat. Healthy fat are those that come from plants such as olives, nuts, and avocados. Protein, the amount of daily protein in the diet for people with diabetes and normal kidney function is the same as the general population. The ADA recommends individualizing protein intake. Teach patients to choose lean protein whenever possible. In terms of alcohol, alcohol inhibits gluconeogenesis by the liver. This can cause severe hypoglycemia in people who take insulin or OAs that increase insulin secretion. Alcohol use can make diabetes mellitus hard to manage. Create a trusting environment in which patients feel comfortable talking openly about their alcohol use. Moderate alcohol use can be safely included in a meal plan if the person monitors their glucose and is not at risk for other alcohol-related problems. You know, they give you the recommendation, limit to moderate amount if no risk, 1 drink per day for women, 2 drinks per day for men. Patient teaching related to nutrition therapy. Most often the dietitian initially teaches the principles of nutrition management. Whenever possible, work with the dietitian. Some patients who have limited insurance or who live in remote places do not have access. In these cases, the nurse assumes the responsibility for teaching the basic nutrition principles to the patient with diabetes. We can do carbohydrate counting. That's a meal planning technique used to keep track of the amount of carbohydrate eaten at each meal per day. Teach the patient to keep the intake within a healthy range. The amount of total carbohydrate per day will depend on the glucose levels, the age, the weight, the activity level, patient's preference, and the drug plan. The serving size of carbohydrate is 15 grams. A typical adult might start with 45 to 60 grams of carbohydrate per meal. Some patients tailor their insulin doses to the amount of carbs they will consume at the meal. And the diabetes exchange. The diabetes exchange lists are another method for meal planning. Instead of counting carbs, a person uses a meal plan with specific numbers of helping from a list of exchanges for each meal and snack. The exchanges are starches, fruits, milk, meat, vegetables, fats, and free food. The person chooses foods from the various exchange based on the prescribed meal plan. This method may be easier for some people than carbohydrate counting. It encourages a well-balanced meal plan. Another advantage is that this approach helps a person limit their portion size, their overall food intake, and an important part of their weight management. Then there is the My Plate method. This helps the person see how much vegetable starch and meat should fill a 9-inch plate. The recommendations is that each meal has half of the plate filled with non-starchy vegetables, 1/4 filled with the starch, and 1/4 with the protein. And then an 8-ounce glass of non-fat milk and a small piece of fresh fruit complete the meal. Whenever possible, we are to include family members and caregivers in the nutrition education and counseling, especially the person who cooks for the household. However, the responsibility for maintaining a healthy eating plan belongs to the person with the diabetes. Reliance on other persons to make health decisions interferes with that patient's ability to develop self-care skills, which are essential in managing diabetes mellitus. Foster independence, even in the patient with visual or cognitive problems. In terms of exercise, regular consistent exercise is an essential part of diabetes and pre-diabetic management. The ADA recommends that people with diabetes engage in at least 150 minutes per week. That's 30 minutes for 5 days a week of a moderate intensity aerobic activity. The ADA encourages people with diabetes to perform resistance training 2 to 3 times a week unless contraindicated. Exercise decreases insulin resistance and can have a direct effect on lowering glucose levels. Encourage patients to be active every day and decrease the amount of time sitting. Medical decrease may be medical clearance may be needed for new intensive exercise programs. Teach the patients to start slowly and gradually progress toward their desired goal. We look at the benefits of exercise. The glucose lowering effects of exercise can last up to 48 hours after activity, so it is possible for hypoglycemia to occur long after the activity. People who use drugs that can cause hypoglycemia should exercise about 1 hour after a meal, or have 10 to 15 grams of carbohydrate snack, and check their glucose before exercising. It is preferable not to increase caloric intake for exercise. If needed, they can eat small carbohydrate snacks every 30 minutes during the exercise to prevent hypoglycemia. Patients using drugs that place them at risk for hypoglycemia should always carry a fast-acting source of protein, such as glucose tablets or hard candy when exercising. If they have frequent loss or lows from exercise, the dose may need to be lowered. The body can perceive strenuous exercise as stress, causing a release of counter-regulatory hormones and a temporary increase in glucose. A patient with type 1 who has hyperglycemia and ketones, exercise can worsen these conditions. Teach these patients to delay activity of the glucose level until we see results 250 milligrams per deciliter and ketones present in the urine. If hypoglycemia is present without ketones, it is not necessary to postpone the exercise. I've gone over the information on slide 486. You read back through it again. Risk for hypoglycemia when exercising: carry fast-acting source of carbohydrates. If frequent low glucose from exercise, consult the healthcare provider about lowering the medications. Strenuous exercise can be perceived as stress by the body. You may get a temporary increase in glucose. And type 1, there may be delayed activity if the glucose is greater than 250 and ketones are present in the urine. This all makes the condition worse. Blood glucose monitoring is a critical part of diabetes management by providing a current glucose reading. The BGM lets the patient make decisions about food intake, activity tolerance, and drug dosages. It produces accurate records of daily glucose fluctuation trends and alerts the patient to acute episodes of hyperglycemia and hypo. We call it BGM. It provides patients with a tool for achieving and maintaining specific glycemic goals. It is recommended for all people who use insulin to manage their diabetes. Other patients with diabetes use blood glucose monitoring to help achieve and maintain glycemic goals and monitor for acute fluctuations in glucose related to drugs, food, and exercise. So let's look at monitoring glucose, monitoring blood glucose. Blood glucose monitoring, or BGM, is a critical part of diabetes management. By providing a current glucose reading, it lets the patient make decisions about food intake, activity patterns, and drug dosages. It produces accurate records of daily glucose fluctuation trends and alerts the patient to acute episodes of hyperglycemia and hypoglycemia. Provide patients with tools for achieving and maintaining specific glycemic goals. It is recommended for those who use insulin to manage their diabetes. Other patients use it to help achieve and maintain glycemic goals and monitor for acute fluctuations related to drugs, food, and exercise. The frequency depends on several factors. These include the patient's goals, type of diabetes, drug plan, patient's ability to check it, independent access to supplies and equipment, and the patient's willingness and ability to do so. The recommendation for people who use multiple insulin injections or pumps is to monitor their glucose 4 to 8 times a day. Patients using less frequent insulin injections, non-insulin therapy, or nutrition management may use it as often as needed to achieve their glycemic goals. People who perform BGM use portable blood glucose meters. A wide variety of meters are available. Disposable lancets are used to get a small drop of capillary blood. It's usually a finger stick that is placed in a reagent strip. After a specified time, the meter will display a reading. Technology is rapidly changing. More convenient systems are introduced on an ongoing basis. CGM systems are another route for monitoring. More people with type 1 are using CGM. These systems are slowly being used by more people with type 2. Insurance coverage and cost are the most common limiting factors. Some insulin pumps have CGM integrated as part of the system. We talk about portable glucose meters for BGM. Many products available: lancet for small drop of blood, finger stick, reagent strip, meter displays a digital reading. Technology changing rapidly with newer and more convenient systems introduced. Using a sensor inserted subcutaneous, the CGM systems display new glucose levels every 1 to 5 minutes, assesses interstitial blood, which lags behind blood glucose by 5 to 10 minutes. The patient inserts the sensor using an automatic insertion device. Data is sent from the sensor to a transmitter, which displays the glucose value on either an insulin pump or page-like receiver. It can be used with or without a pump. Newer CGMs can share data with smartphones. CGMs help the patient and healthcare provider identify trends and patterns in levels. The goal is to increase time in range 70 to 180 and have fewer highs and lows. They are useful for managing insulin therapy or when continuous glucose readings are important. These meters are reliable when used consistently correctly. It is not necessary to compare their readings to laboratory readings. If the A1C results does not correspond to the glucose reading on the home meter, troubleshoot any problems with the meter, technique, strips, and hand washing. And we've gone over this. As said, continuous glucose monitoring is used for type 1 or 2. Insurance coverage and costs is what limits the use. Some pumps have it integrated. It helps to identify trends and patterns. The goal is to increase time and range, alert the person to either hypo or hyperglycemia. You have to do patient and caregiver teaching. Teach the patients to check the glucose levels whenever they suspect hypoglycemia, then take immediate action. During times of illness, check it levels at 4-hour intervals or more to determine the effects of illness on glucose level. Teach the patient to check before and after exercise to determine the effects of exercise. This is especially important for patients with type 1. We have to keep in mind impaired vision, cognition, and dexterity. Use adaptive devices and identify who the caregiver is. We're going to go on to transplantation. Pancreas transplantation is an option for select persons with type 1 diabetes. Candidates include patients who have RD and have had or plan to have a kidney transplant. Kidney and pancreas transplants are often done together, or pancreas may be transplanted after a kidney. If renal failure is not present, the ADA recommends that pancreas transplantation be considered only for people who meet 3 criteria. There's a history of frequent, acute, or severe metabolic complications like hypoglycemia and hyper DKA requiring medical attention, and then clinical and emotional problems with the use of insulin therapy that are so severe as to be incapacitating, and consistent failure of insulin-based management to prevent acute complication is present. If the transplant is successful, it will improve the quality of life. It eliminates the need for insulin therapy and frequent blood glucose monitoring. It can eliminate acute complications and type 1. Long-term renal therapy and neuro complications may persist. Patient might have lifelong immunosuppression. Option for islets cell transplantation, donor islet cells infused into portal vein to liver, pain and recovery time less than with the pancreas transplant, experimental in the United States, still at this point. When we talk about that subjective data, you look at that patient history, what they have said it is, what they've said they've gone through, their trauma, their infection, their stress, pregnancy, pancreatitis, Cushing's, acromegaly, family history of diabetes. We want to get all of this information. We want to find out what medicines the patient's on, insulins, OAs, corticosteroids, diuretics, phenytoin. What medicines is driving this patient to stay on these meds and stay at home? Recent surgery or other treatment. You want to find that out from the patient. You're looking at that subjective data on the patient we're gathering. What is the functional health pattern? What is their health perception? What do they see about themselves, their age, and what is happening in terms of the present condition? Is there positive family history? Is there malaise? You want to look at nutrition, what are the metabolic symptoms? Is there obesity or weight loss or gain, or thirst or hunger? Is there poor healing, diet compliance? Is there elimination problems like constipation, diarrhea, frequent urination, bladder infections, nocturia, urinary continence? We want to get all of this subjective data in terms of the patient's functional patterns. And then you want to get their activity, their cognition, and their sexual information all gathered, okay? Then you're doing your nursing assessment, your functional health patterns. How are they coping with stress? What are their value belief systems? Are there support by those systems to help keep them connected to their lifestyle? Then we do the objective data, which is the actual physical assessment itself, and that's when we examine the patient from heart to head to toe, and we gather information, and we may have to go back and gather some more. Objective data: eyes soft, sunken eyeballs, history of vitreous or vitreal hemorrhages, cataracts. Integumentary is the skin dry, warm, inelastic, pigmented skin lesions, ulcers, loss of hair on toes, acanthosis nigricans in the respiratory system, Kussmaul breathing, cardiovascular. Does a patient have a history of hypertension, weakness, or rapid pulse, weak or rapid pulse? Then you get your objective data. You're now doing the actual physical assessment, gastrointestinal, dry mouth, vomiting, fruity breath, altered reflexes, restlessness, confusion, stupor and coma, neurological, and is there muscle wasting? And you're going to look at those diagnostic tests and look and see, what are those values? What is that serum electrolyte abnormalities? What are the A1C levels? Fasting glucose level 126 or higher. Has it been that? Oral glucose tolerance test, has it exceeded 200? Is there leukocytosis? Is a BUN and creatinine within normal levels? So you look at those possible diagnostic tests. So altered blood glucose levels, deficient. These are the clinical problems that the nurses will see on slide 103. Altered glucose levels, deficient knowledge, risk for injury, impaired endocrine function, and neurological problem. We're looking at that care plan format. And what is my planning? The overall goals. What are the overall goals? The patient will engage in self-care to actively manage diabetes, few or no hypoglycemia emergency, maintain safe and healthy glucose levels, reduce risk for chronic complications, and they'll adjust their lifestyle to accommodate their plan for treating, managing their condition. So when we look at the implementation and health promotion, your role in health promotion is to identify, monitor, and teach the patient at risk for diabetes mellitus. Obesity is a key factor for type 2. The ADA recommends routine screening for type 2 for adults who are overweight or obese, that BMI being 25 kilograms per m squared or greater, or have one or more risk factors. The ADM risk test is available on the website. The DM risk test determines if the person is at risk for prediabetes or diabetes. For people who do not have risk factors, begin screening at age 45. Primary prevention is cost-effective approach. Look at box 53.3. Current recommendations for primary prevention include lifestyle modification for at-risk people, a modest weight loss of 5 to 7% of body weight, and 150 minutes of physical exercise a week. This lowers the risk for developing type 2 diabetes by 34 to 58%. When it talks about acute care, acute situations involving the patients with diabetes include hypoglycemia, DKA, hyperosmolar hypoglycemic syndrome, that's HHS. Management for these will be discussed. Other areas of acute care relate to management during acute illness and surgery. And then, of course, we got acute illness and surgery itself. Emotional physical stress can increase glucose levels and cause hyperglycemia. Stress is unavoidable. Certain situations may require more intense treatment, like extra insulin and more frequent BGM to maintain glycemic goals and avoid hypoglycemia. Acute illness and surgery, emotional and physical stress, as I said, increases glucose levels and cause hyperglycemia. Stress is unavoidable. As we already said, certain situations may require more intense therapy. Patient may have to get a little extra insulin and more frequent BGM to maintain glycemic goals and avoid hyperglycemia. As we're looking at our slide, physical and emotional stress, already said, glucose levels increase secondary to counter-regulatory hormones that cause hyperglycemia. Encourage patients to check their glucose at least every 4 hours when they are ill. If the glucose is greater than 240, check their urine for ketones. Persons with diabetes 2 may need insulin therapy during illness. We want to, when we're going through acute illness, maintain normal diet, if able, increase non-caloric fluids, continue taking diabetic medications. If they're eating less than normal, supplement with carbohydrates containing fluids while continuing medication. If unable to eat or drink, contact the healthcare provider. And the intraoperative period. So during the intraoperative period, we often adjust the diabetes mellitus plan to ensure safe and healthy glucose levels. The patient receives IV fluids and insulin if needed just before, during, and after surgery when there's no oral intake. Explain to the patient with diabetes 2 who has been taking OAs that this is a temporary measure, not a sign of worsening diabetes. When caring for an unconscious surgical patient receiving insulin, be sure to be alert for signs of hypoglycemia such as sweating, tachycardia, tremors. Frequent glucose monitoring can prevent episodes of hypoglycemia. We talk about ambulatory care. Successful diabetes management involves ongoing interaction among patients, caregiver, and the healthcare team because it is a complex condition. Diabetes, there a great deal of patient contact takes place in outpatient and home settings. The major goal of patient care is to enable the patient, with the help of a caregiver, to reach optimal level of independence and self-management. So many patients are facing challenges in reaching their goals. Diabetes increases the risk for other chronic conditions that can affect self-management, and these include impaired vision, lower extremity problems that affect mobility, and other functional limitations. Other barriers may include feelings of inadequacy about their abilities, unwillingness to make behavioral changes, ineffective coping, and cognitive problems. Assess the patient's ability and the caregivers in performing activities such as BGMs and insulin injection. Assistive devices for self-administration include syringe magnifiers, vial stabilizers, dosing agents for visually impaired. assess the patient's and the caregiver's ability to form BGM and insulin, obtain assistive devices, and refer to resources that need it. Self-management requires dedication of time and energy to deal with lifestyle choices, to deal with the diet, to deal with medications, exercise, and the prevention of or managing of complications. So we have to have a lot of patient and caregiver education. That is of the utmost importance. You have to assess the patient's knowledge of the condition and lifestyle preferences when planning a teaching plan. We have to assess the meaning of diabetes mellitus. Okay, what does it mean to the person to have it? Assess their knowledge frequently so that you can help to with gaps in knowledge or correct misinformation. Identify the patient's support systems. Include them in the planning and teaching and counseling. When we include family members and other persons close, they can support the patient's management. They can also provide care if self-care is not possible. Encourage the family and the caregivers to provide emotional support and encouragement as the patient deals with the reality of living with a chronic disease. The goal of diabetes education is to match the level of self-management to the patient's ability. They can become most active. Patients who actively manage their diabetes mellitus care have better outcomes than those who do not. We call this empowerment approach to education. There's free educational materials available that we can give to patients and caregivers. Let's talk a little bit about insulin therapy. The nurse's responsibility for the patient receiving insulin include proper administration, assessing response to insulin therapy, and teaching the patient about administration, storage, and side effects of insulin. We do our assessment. We assess the newer use of insulin for their ability to safely maintain therapy. So this includes the ability to understand and the interaction of insulin, food, and activity, and to become more and to become so retracting a little bit, it was not to become and to recognize and treat the symptoms of hypoglycemia appropriately. If the patient does not have the cognitive skills to do these things, identify and teach another responsible person. The patient or caregiver must have the cognitive and manual skills needed to prepare and inject insulin. Other additional resources will be needed to assist the patient. For patients with cognitive, physical, and other barriers, consider referral to CDCES or CDCES. ACDCES has the specialized knowledge and skills to promote self-care behaviors for these patients. Oral and non-insulin injectable agents. The nurse's responsibility for the patient taking OAs and non-insulin injectable agents are similar to those for patients who are taking insulin. Proper storage and administration, assessing the patient's use and response to these drugs, and teaching the patient and the family are the essential nursing actions. The assessment is valuable in determining the most appropriate drug for the patients. Factors such as the patient's mental status, their like today is Monday. We look at what is the mental status of the patient, what is the eating habits, what is their home environment like, what is their learning ability, their resources, and then most of all, what is their attitude toward diabetes mellitus, and the medication history. All of this plays a significant role in determining the most appropriate drug for the patient. For example, a frail older adult who lives alone are at high risk for severe hypoglycemia because the low glucose is often undetected or untreated. This is especially true for patients with cognitive impairment, those with cases or OA that does not cause hypoglycemia or shorter action, okay, or shorter acting OA would be most appropriate. Patient teaching is essential. Some patients may assume that their DM is not a serious condition if they're only taking a pill to treat it. Teach the patient that OAs help manage glucose and prevent serious long and short-term complications. So we have to determine the most appropriate drug for the patient. And in doing that, we've got to consider their mental status, the eating status, home environment, learning ability, resources, attitudes, and medicines. In terms of personal hygiene, potential for infection requires diligent skin and dental hygiene practices. Because of the susceptibility to periodontal disease, encourage daily brushing and flossing and regular dental visit. When having dental work done, teach the patient to tell the dentist they have diabetes mellitus. Routine care includes regular bathing with an emphasis on foot care. Teach the patient to keep their teach the patient to inspect their feet daily and avoid going barefoot, and wear shoes that are supportive and comfortable. If cuts, scrapes, or burns occur, treat them promptly and monitor them carefully. Wash the area and apply a non-abrasive or non-irritating antiseptic ointment. Cover the area with dry sterile pad. Teach the patient to notify the HCP at once if injury does not begin to heal within 24 hours or if signs of infection develop. We talk about medication identification and travel. Teach the patient to always carry medical identification indicating they have diabetes. Police, paramedics, and many private citizens know to look for this identification when working with sick or unconscious patients. So you can have an identification card that can supply valuable information such as the name of your healthcare provider, your type of diabetes, the type and the dosage of insulin or non-insulin injectable agents or OAs. Looking at our card here, plan ahead for travel. Travel for a person with diabetes requires planning. Being sedentary for long periods may raise a person's glucose level. Encourage them to get up and walk at least every 2 hours to lower the risk for deep vein thrombosis and prevent high glucose. Teach them to have a full set of diabetes care supplies in their carry-on luggage when traveling by plane, train, or bus. This includes their BGM equipment, insulin, non-insulin injectable agents, OA syringes, insulin pens, and pins and needles. Best practice for traveling with diabetes supplies: change frequently. Encourage patients to check TSA guidelines before traveling. There is a website. Notify screeners if an insulin pump is used so that they can inspect it while it is on the body rather than removing it. For patients who use insulin or OAs that cause hypoglycemia, keep snack items and quick-acting carbohydrate source for treating hypoglycemia in the carry-on luggage. There are alerts that you see on figure 116. I have diabetes, and it tells them a certain information as to what to do. In terms of evaluation and expected outcomes, the expected outcomes are that the patient with diabetes mellitus will state key elements of the treatment plan, describe measures that they may prevent a slow progression of chronic complications, maintain a balance of nutrition, activity, and insulin availability that results in stable, safe, and healthy glucose levels, have no injury from decreased sensations in the feet. We're going to look at acute complications of diabetes. Acute complications of diabetes arise from events associated with hyperglycemia and hypoglycemia. Hyperglycemia, high glucose, occurs when there's not enough insulin working. Hypoglycemia, low glucose, occurs when there's too much insulin working. Many signs of hyperglycemia and hypo overlap. Sometimes it's hard to tell the difficulty, but tell the difference, but it's important to distinguish between them because hypoglycemia worsens rapidly and is a serious threat if action is not immediately taken. So let us begin. Our situations are hypoglycemia, hyperglycemia, diabetic ketoacidosis, and hyperosmolar hypoglycemic syndrome, or HHS. So we're going to look at diabetes-related ketoacidosis. DKA is caused by a profound deficiency of insulin. It is characterized by hyperglycemia, ketosis, acidosis, and dehydration. It is most likely to occur in people with type 1. It may occur in type 2 in conditions of severe illness or stress in which the pancreas cannot meet the extra demand for insulin. The precipitating factors include illness, infection, inadequate insulin dosage, undiagnosed type 1, lack of education, understanding, or resources, and neglect. When circulating supply of insulin is insufficient, glucose cannot be properly used for energy. The body compensates by breaking down fat stores and secondary source of fuel. Ketones are acidic byproducts of fat metabolism that can cause serious problems when they become excessive in the blood. For this slide here, I already gave those factors, but let me just read back through those again and we'll go on to the next one. The precipitating factors include illness, infection, inadequate insulin dosage, undiagnosed type 1 diabetes mellitus, lack of education, lack of understanding, lack of resources, and neglect. So when we are dealing with a situation where we have insulin deficiency, the body burns fat as a fuel source. Byproducts of fat metabolism are acidic ketones, and they alter the pH and cause us to go into metabolic acidosis. Ketones excreted in the urine along with the electrolytes and become cations. There's impairment of protein synthesis. It causes protein degradation, resulting in nitrogen loss from tissues. So insulin deficiency will stimulate glucose production from amino acids in the liver, leading to further hypoglycemia. Hyperglycemia may cause osmotic diuresis. So without treatment, severe depletion of sodium, potassium, chloride, magnesium, and phosphate occur. So then we get acidosis and we get vomiting and further fluid and electrolyte loss. Your insulin deficiency impairs protein synthesis, causes excessive protein degradation, resulting in nitrogen losses from the tissue. The deficiency stimulates glucose production from amino acids, which are proteins in the liver, and it leads to further hypoglycemia. Because of the insulin deficiency, the body cannot use the additional glucose, and the glucose level rises further. This adds to osmotic diuresis. If it is not treated, the patient will develop severe depletion of sodium, potassium, chloride, magnesium, and phosphate. Vomiting that is caused by acidosis results in more fluid and electrolyte losses. Eventually, hypovolemia followed by shock will occur. Renal failure, which may eventually occur from hypovolemic shock, causes the retention of ketones and glucose. The acidosis will progress. Untreated, the patient becomes comatose from dehydration, electrolyte imbalance, and acidosis. If it is not treated, death is inevitable. So we'll talk hypovolemia. It will be followed by shock, can cause renal failure, cause retention of ketones and glucose, and further acidosis. So we'll have dehydration, electrolyte imbalance, and acidosis, causing coma, and if not treated, death. You'll see the pathology of diabetic ketoacidosis on this slide. Please take some time and review it. And when we talk about, we have dehydration, where I have dry mucous membrane. These are the clinical signs and symptoms. Dry mucous membranes, tachycardia, orthostatic hypotension. Early symptoms will include lethargy and weakness. And as the patient becomes severely dehydrated, the skin will become dry and loose. The eyes become soft and sunken. The abdominal pain may be present and accompany anorexia, nausea, and vomiting. Acetone is noted on the breath as sweet, fruity odor, and the person will go on to Kussmaul respiration. Okay, so we see this here on 127. All the things that will progress that I just said: dry skin, loose, eyes sunken, abdominal pain, anorexia, nausea, and vomiting, Kussmaul respiration, sweet, fruity breath odor from the acetone. Glucose levels are greater or equal to 250. Blood pH lower than 7.30. Sodium bicarb levels will be less than 16, and moderate to high ketone levels will be in the urine and the blood. Less severe form may be treated on an outpatient basis. The factors that will cause hospitalization: severe fluid and electrolyte imbalance, fever, nausea, vomiting, diarrhea, altered metastasis, the cause of the DKA, the ability to communicate with health provider every few hours. The emergency management, ensure patient airway, administer oxygen, establish IV access, begin fluid resuscitation to replace extracellular, intracellular fluid, and correct the electrolyte imbalance. These are the typical fluids you would get: sodium chloride or saline. Add 5%, 10% dextrose when glucose levels approach 250. Restore urine output to 30 to 60 milliliters per hour. You want to protect the patient from cerebral edema, monitor fluid overload, renal or cardiac compromise. We're still talking about DKA, interprofessional care. It's a serious condition that proceeds rapidly and must be treated promptly. Hospitalization may not be needed to treat the patient. If fluid and electrolyte imbalances are not severe and glucose levels can safely be monitored at home, DKA can be managed on an outpatient basis. Other factors to consider when deciding Whether we manage the patient include the presence of fever, nausea, vomiting, and diarrhea, altered mental status, and the cause of the DKA. The availability of communication with her, you want to look at tape 5320 for the emergency management of the patient with DKA. Because fluid imbalance is potentially life-threatening, the first goal is to establish IV fluid. Establish an IV access so we can give IV fluids, and then we begin fluid and electrolyte replacement. Typically, the initial fluid therapy involves IV infusion of half normal saline or normal saline, okay, at a rate to raise the blood pressure, restore urine output to 30 to 60 milliliters per hour. When the glucose levels approach 250, dextrose is added to prevent hypoglycemia and such sudden drops in glucose that cannot cause cerebral edema. Rapid rehydration, especially with hypotonic IV fluids, can cause cerebral edema. Let's look at hyperosmolar hypoglycemia syndrome, HHS. It is a life-threatening syndrome that can occur in patients with diabetes mellitus who are able to make enough insulin to prevent DKA, but not enough to prevent severe hypoglycemia, osmotic diuresis, and extracellular fluid depression. HHS is less common than DKA. It often occurs in patients over 60 of age with type 2 diabetes. Common causes. You have a graph to look at on page 132 to help you understand the physiology. Common causes include UTIs, pneumonia, sepsis, and acute illness, and newly diagnosed type 2 diabetes. HHS is often related to impaired thirst sensation and or functional inability to replace fluid. There's a history of inadequate fluid intake, increasing mental depression or impaired cognition, and polyuria. The main difference between HHS and DKA is that patients with HHS usually have enough circulating insulin so that ketoacidosis does not occur. Because HHS has fewer symptoms in the earlier stages, glucose levels can climb quite high before the problem is recognized. The higher glucose levels increase serum osmolality and cause more severe neurological manifestations like somnolence, coma, seizures, hemiparesis, and aphasia. Since these manifestations resemble a stroke, immediate determination of the blood glucose level is critical for correcting the diagnosis and treatment, or for making the correct diagnosis and developing a plan of treatment. Ketones are usually absent or minimal in the blood and the urine. On the interprofessional care, HHS is a medical emergency. It has a high mortality rate. The management is similar to DKA. It includes immediate IV administration of insulin and either 9% or 0.45 sodium chloride. It requires large volumes of fluid replacement. This should be done slowly and carefully. Patients with HHS are often older and may have heart or kidney problems, requiring hemodynamic monitoring to avoid fluid overload during fluid replacement. When glucose levels fall to above 250, IV fluids containing dextrose are given to prevent hypoglycemia. Electrolytes are monitored and replaced as necessary. Hypocalcemia is not a significant and HHS. That's hypokalemia, not calcemia. Hypokalemia is not as significant in HHS as it is in DKA, although fluid losses may result in milder potassium deficit and require replacement. Assess the vital signs, the intake and output, the lab values, and cardiac monitoring to check the efficacy of fluid and electrolyte replacement. This includes monitoring serum osmolality and frequently assessing cardiac and renal and mental status. Once the patient is stable, begin attempts to detect and correct the underlying cause. So look at slide 135. Management similar to DKA. We got insulin and sodium chloride infusions. Add dextrose when the glucose levels get around 250. More fluid replacement is needed. Hemodynamic monitoring is needed to avoid fluid overload. Monitor fluid and electrolytes, potassium, serum osmolality, INO, skin tugger, neurorenal and cardiac status, and always we're working at correcting the underlying precipitating cause. Under nursing management, monitor the glucose. We closely monitor the hospitalized patient with appropriate blood and urine tests. We have to monitor the glucose in the urine output and ketones and use laboratory data to determine appropriate patient care. We want to monitor the administration of IV fluids to correct dehydration, insulin therapy to reduce glucose and serum ketone levels, and electrolytes given to correct electrolyte problems. Assess renal status and cardiopulmonary status related to rehydration and electrolyte levels, and monitor the patient's level of consciousness. Assess for signs of potassium imbalance resulting from low levels of insulin, osmotic diuretics. When insulin treatment is started, potassium levels may rapidly decrease. So we need to make sure that we're monitoring them because potassium is moving into the cells once insulin is available. The movement of potassium into and out of the extracellular fluid influences cardiac functioning, so make sure that cardiac monitor is on. We assessed renal status, cardiopulmonary status, and the level of consciousness on these patients. When we're looking at hypoglycemia or low glucose, occurs when there's too much insulin in proportion to available glucose in the blood. This causes blood levels to drop to less than 70. When glucose drops below 70, the body releases counterregulatory hormones and activates the autonomic nervous system. Suppressing insulin secretions and producing glucagon and epinephrine provide a defense against hypoglycemia. We talk about hypoglycemia and the common manifestations of it. They can occur with a very high glucose level and falls too rapidly. Continuing with hypoglycemia, just to refresh some concepts as we move on. Epinephrine Release causes manifestations that include shakiness, palpitations, nervousness, diaphoresis, anxiety, hunger, and pallor. Because the brain needs a constant supply of glucose in sufficient quantities to function properly, hypoglycemia can affect mental functioning. These neuroglycopenia manifestations are difficulty speaking, visual changes, stupor, confusion, and coma. Manifestations of hypoglycemia can mimic alcohol intoxication. Untreated hypoglycemia can progress to loss of consciousness, seizure, coma, and death. Then we go on to hypoglycemia unawareness. It is a condition in which a person does not have the warning signs and symptoms of hypoglycemia until the glucose reaches a critical point. Then the person may become incoherent and combative or lose consciousness. This is often a result of diabetes mellitus-related autonomic neuropathy that interferes with the secretion of counter-regulatory hormones that cause these symptoms. Patients at risk for hypoglycemic unawareness include those who have had repeated episodes of hypoglycemia, older adults, and patients who use beta-adrenergic blockers. Using intensive treatment to lower glucose levels in patients who have or are at risk for hypoglycemic unawareness may not be an appropriate goal. These patients usually keep their glucose levels somewhat higher than those who can detect and manage the onset of hypoglycemia. The causes of hypoglycemia are often related to a mismatch in the timing of food intake and the peak action of insulin or OAs that increase insulin secretion. Common causes include receiving too much insulin or medication, ingesting too little food, delaying the timing of eating, and performing unusual or unexpected exercise. Hypoglycemia can occur at any time, and it most often occurs when OA or insulin is at its peak of action or when the patient's daily routine is disrupted without adequate adjustment in diet, drugs, and activity. Hypoglycemia is most common with insulin therapy. It can occur with non-insulin injectable agents and OAs and may persist for an extended time because of the longer duration of action of these drugs. And the symptoms of hypoglycemia may occur when a very high glucose level falls too rapidly. An example, the glucose level of 300 milligrams per deciliter falling quickly to 150. Although the glucose level is above normal by definition and measurement, the sudden metabolic shift can cause hypoglycemic symptoms. Aggressively managing glucose levels, lowering high glucose levels for the first time, or lowering glucose with insulin after a long period of hyperglycemia can cause this situation. For still on management for this condition is quickly reversible. Check the glucose levels. If it's less than 70, begin treatment. If greater than 70, investigate further for cause of the signs and symptoms. If monitoring equipment not available, treatment should be initiated. If a patient has manifestation of hypoglycemia and the monitoring equipment is not available, or the patient has a history of fluctuating glucose, assume hypoglycemia and start treatment. The treatment rules. Follow the treatment rule of 15 to treat hypoglycemia. That's table 53.21. A glucose value less than 70 is treated by ingesting 15 to 20 grams of simple fast-acting carbohydrates like 4 to 6 ounces of fruit juice or a regular soft drink Encourage the patient to carry or have available glucose tablets, gels, and powders for use in such situations. Recheck the glucose 15 minutes later. If the value is less than 70, ingest 15 to 20 grams more of carbohydrate and recheck the glucose in 15 minutes. If no significant improvement occurs after 2 to 3 doses, contact the healthcare provider. After an acute episode of hypoglycemia, the patient may need a snack and carbohydrate and protein if the next meal is more than an hour away or if they are being active. Avoid treatment with carbohydrates that contain fats, such as candy bars, cookies, whole milk, or ice cream. The fat in these foods will slow glucose absorption and delay response to treatment. Do not overtreat with large quantities of quick-acting carbohydrates because a rapid fluctuation to hyperglycemia can occur. When we talk about treatment in acute care settings, patients with hypoglycemia may receive 20 to 50 milliliters of dextrose, 50%. If the patient is not alert enough to swallow or no IV access is available, another option is to give 1 milligram of glucagon by IM or subcutaneous injection. An IM injection in a site such as a deltoid muscle will result in a quicker response. Glucagon stimulates the liver to convert glycogen to glucose and makes glucose rapidly available. Nausea is a common reaction after glucagon injection. To prevent aspiration or vomiting, if vomiting occurs, turn the patient on the side until they are alert. Patients with minimal glycogen stores will not respond to glucagon. This includes patients with alcohol-related liver disease, starvation, and adrenal insufficiency. Teach family members and others likely to be present if severe hypoglycemia occurs when and how to inject glucagon. Once the episode is resolved, explore with the patient the reasons why the situation developed. This assessment may indicate the need for further patient teaching to avoid future episodes of hypoglycemia. We will now go on to chronic complications of diabetes. Chronic complications associated with diabetes. You'll see the chart on slide 146, 53.14, long-term complications of diabetes. And just take time and go through those before the time frame of getting through the audio. I won't read through the slide. Let's look at angiopathy. Chronic complications associated with diabetes mellitus are primarily those of end-organ disease from damage to blood vessels. Angiopathy from chronic hyperglycemia. Angiopathy is the leading cause of diabetes mellitus-related death, with about 68% of death caused by cardiovascular and 16% by strokes for those age 65 or older. The chronic blood vessel dysfunction are divided into two categories, that is microvascular, MAC, and MIC, vascular complications. There are several theories that exist as to how and why chronic hyperglycemia damages cells and tissues. Possible causes include the accumulation of damaging byproducts of glucose metabolism, such as sorbitol, which damage nerve cells. Second, the formation of abnormal glucose molecules in the basement membrane of small vessels, such as those that circulate to the eyes and kidneys. 3, a problem with RBC function that leads to a decrease in tissue oxygenation. The Diabetes Control and Complication Trial, DCCT, a landmark study in diabetes management, showed the risk for microvascular complication is reduced in people with type 1 by keeping glucose levels as near to normal as possible for as much of the time as possible. It's called a tight or intensive therapy. Okay, and I just sort of went over that the previous slide. The diabetic control and complication trial, DCCT, patients with type 1 diabetes could significantly reduce the risk of microvascular complication by keeping the glucose level near normal most of the time, and it's a tight or intensive therapy. We decrease retinopathy, we decrease nephropathy. The basis for the ADA recommendation for near normal glucose levels. Of course, these were based on the findings. The ADA issued treatment goals to maintain glucose levels as near to normal as possible. Specific targets for each patient must consider their risk for severe or undetected hypoglycemia as a side effect of intensive management. Long-term complications are devastating. People with diabetes need scheduled and ongoing monitoring for the detection and prevention of chronic complications. The ADA recommendations for ongoing evaluations are shown in Table 53.22. It is essential that patients understand the importance of regular follow-up visits. You need to have an annual exam, retinopathy, nephropathy, neuropathy, comprehensive foot exam, cardiovascular risk factor assessment, as needed, or every visit with the HCP, foot and lower extremity exam, exercise stress testing, and daily foot exam by the patient. We move on to look at microvascular complications. Microvascular complications are diseases of the large and medium-sized blood vessels that occur with greater frequency and with an earlier onset in people with diabetes mellitus. This microvascular disease includes cerebrovascular, cardiovascular, and peripheral vascular disease. Women with diabetes have a 4 to 6 times increased risk for CVD. Men with diabetes have a 2 to 3 times increased risk for CVD compared with those without it. There are several modifiable risk factors associated with microvascular complications. These include obesity, smoking, hypertension, high fat intake, sedentary lifestyle. The ADA recognizes that diabetes mellitus alone is a CVD risk factor. The ADA recommends yearly screening for CVD risk factors in people with diabetes mellitus. Insulin, don't want to get. Let's read the slide on 153. Decrease and treat CVD risk factors is a recommendation. Obesity, we need nutrition and exercise, nutritional adjustment really, and exercise. Smoking causes blood vessel disease, strokes, and lower extremity amputation. We would begin to lessen this. With hypertension, we'd optimize blood pressure, we'd decrease that CV and renal disease. High fat intake, dyslipidemia, take the statins, and lifestyle interventions will help to decrease this. And a sedentary lifestyle will be adjusted through exercise. When we talk about microvascular complications, they result from thickening of the vessel membranes of the capillaries and arterioles. These are our small vessels in response to chronic hyperglycemia. Although microangiopathy can be found throughout the body, the areas of most notably affected are the eyes, retinopathy, the kidneys, nephropathy, and the nerves, neuropathy. Microvascular changes are present in some people with diabetes type 2 at the time of diagnosis. Now we move on to retinopathy. Diabetes-related retinopathy refers to microvascular damage to the retina because of chronic hyperglycemia and nephropathy and hypertension in people with diabetes mellitus. Diabetes-related retinopathy is a leading cause of new cases of adult blindness. There are two classifications. We classify retinopathy as non-proliferative or proliferative. In non-proliferative retinopathy, the most common form, partial occlusion of blood vessels in the retina, causes microaneurysms to develop in the capillary walls. The walls of these microaneurysms are so weak that capillary fluid leaks out, causing retinal edema and eventually hard exudates on the intraretinal hemorrhaging. These may cause mild to severe vision loss depending on which parts of the retina are affected. If the center of the retina, the macula, is affected, vision loss can be severe. And then, so I went over, started on the previous slide on non-proliferative, but let me go over what the slide that deals with it says. Non-proliferative, we have partial occlusion of small blood vessels in the retina that causes microaneurysm. We have weakened walls that causes fluid leaks resulting in edema and eventually hard exudates or hemorrhages. We have mild to severe loss of vision. And we have that results with damage to the retina, the center area, the macula, and this can be severe. And then we have the proliferative retinopathy. The most severe form involves the retina and the vitreous. When retina hemorrhage capillaries become occluded, the body compensates by forming new blood vessels to supply the retina with blood, a process called neovascularization. These new vessels are very fragile and bleed easily, causing vitreous contraction. Eventually, light cannot reach the retina as the vessels break and bleed into the vitreous cavity. The patient sees black or red spots or lines if these new blood vessels pull the retina while the vitreous contract, causing a tear. Partial or complete retinal detachment will occur. If the macula is involved, vision is lost. Without treatment, more than half of the people with proliferative diabetic retinopathy will be blind. Persons with diabetes mellitus are prone to other visual problems. Glaucoma occurs because of the occlusion of the outflow chamber from neovascularization. This type of glaucoma is hard to treat and often results in blindness. Cataracts develop at an earlier age and progress more rapidly in people with diabetes mellitus. When we talk about the interprofessional care, the earliest and the most treatable stages of diabetes mellitus related retinopathy often cause no changes in vision. Teach the patient with type 2 diabetes to have dilated eye exams by an ophthalmologist or a specially trained optometrist at the time of diagnosis and annually thereafter, or early detection and treatment. Those with diabetes 1 DM need to have a dilated eye exam within 5 years after the onset of diabetes and then annually. The best approach to managing diabetes-related eye disease is to prevent it by maintaining healthy glucose level and managing hypertension. The best approach to managing diabetes mellitus related eye disease is to prevent it by maintaining healthy glucose level and managing hypertension. But the treatments are available. Laser photocoagulation therapy can reduce the risk for vision loss in patients with proliferative retinopathy or macular edema, and sometimes non-proliferative retinopathy. Laser photocoagulation destroys the ischemic areas of the retina that make growth factors that encourage neovascularization. A patient who develops vitreous hemorrhage and retinal detachment may need to undergo vitrectomy. A vitrectomy is the aspiration of blood, membrane, and fibers from the inside of the eye through a small incision just behind the cornea. We can go back to chapter 22 to look a little bit more at photocoagulation and vitrectomy if you need a little bit more revisiting. Fluocinolone acetonide intravitreal implant that's called Iluvien is used to treat retinopathy. Is an injectable micro insert that provides sustained treatment through continuous delivery of corticosteroid fluocinolone acetate for 36 months. Iluvien is injected in the back of the eye with an applicator that uses a 25 gauge needle, which allows for a self-sealing wound. Vascular endothelial growth factor, VEGF, plays a key role for in those developing diabetes-related retinopathy. Is currently being studied. It's a drug that's injected into the eye that blocks the action of the VEGF and reduces inflammation of their effectiveness in treating retinopathy. We move on to nephropathy. We're talking about the kidneys now. Diabetes-related nephropathy is associated with damage to small blood vessels that supply the glomerula of the kidney. It is a leading cause of end-stage renal disease in the United States, seen in 20 to 40% of the people with diabetes mellitus. The risk factors include hypertension, genetic predisposition, smoking, and chronic hyperglycemia. Keeping glucose level in a healthy range is critical in preventing diabetes-related nephropathy. Patients are screened for nephropathy annually and with a random spot urine collection to assess for albuminuria and to measure the albumin to creatinine ratio. Serum creatinine is measured to give an estimate of the glomerular filtration rate and the degree of kidney function. Patients with albuminuria receive either ACE inhibitor drugs, lisinopril, or angiotensin receptor blockers like losartan. Both these drugs are used to treat hypertension and delay the progression of nephropathy in patients with diabetes mellitus. Hypertension significantly accelerates the progression of nephropathy. Aggressive BP management is indicated for patients with diabetes mellitus and hypertension. Patients with diabetes mellitus and hypertension needs aggressive BP management. We will move on to neuropathy. Diabetes-related neuropathy is nerve damage that occurs from the metabolic imbalances associated with diabetes mellitus. 60 to 7% of patients with diabetes have some degree of neuropathy. The most common type affecting persons with diabetes is sensory neuropathy, can lead to the loss of sensation in the lower extremities. Coupled with other factors, it significantly increases the risk for complication that results in lower limb amputation. More than 60% of non-traumatic amputations in the United States occur in people with diabetes mellitus. Neuropathy or neuropathy can precede, accompany, or follow the diagnosis of diabetes mellitus. Screening begins at the time of diagnosis in the patient with type 2 diabetes and 5 years after diagnosis in patients with type 1. Let's look up at the slide just a little bit here. Went through the statistics, went through the sensory area of it, the neuropathy, most common. loss of protective sensation on lower extremities, and it leads to a risk of amputation. And then we screen type 2, time of diagnosis, and type 1, 5 years after diagnosis. So we're dealing with the etiology and the pathophysiology. We do not completely understand the pathophysiology of diabetes-related neuropathy. Diseases include metabolic, vascular, and autoimmune factors. The prevailing theory is that persistent hyperglycemia leads to accumulation of sorbitol and fructose in the nerves that cause damage. How they cause the damage is unknown. The result is reduced nerve conduction, demyelination. Ischemic damage by chronic hyperglycemia in blood vessels that supply the peripheral nerves is implicated in developing diabetes-related neuropathy. Classifications is sensory and autonomic. Sensory neuropathy, the most common form of sensory neuropathy is distal symmetric polyneuropathy. It affects the hands and or feet bilaterally. We sometimes call this stocking glove neuropathy. Characteristics include loss of sensation or abnormal sensations, pain, and paresthesias. Patients describe the pain as burning, cramping, crushing, or tearing. It is usually worse at night and may occur only at that time. The paresthesias may be associated with tingling, burning, and itching sensation. The patient may report a feeling of walking on pillows or numb feet. The skin can become so sensitive, hyperesthesia, that the patient cannot tolerate even slight pressure from bed sheets. Complete or partial loss of sensation to touch and temperature is common. Foot injury and ulcerations can occur without the patient even having pain. Neuropathy can cause atrophy of small muscles of the hands and feet, causing deformity and limiting fine movement. So we look at this. We have paresthesias, tingling, burning, itching, walking on pillows or numb feet, paresthesia. We can have complete or partial loss of sensitivity to touch or temperature. Foot injury and ulcerations can occur without the patient knowing or feeling pain. Small muscles of the hands and the feet may be affected, causing deformity and limited fine movement. And then you see a slide with a picture of neurotrophic ulcerations. Then the sensory neuropathy treatment. Managing glucose is the only treatment for diabetes-related neuropathy. It is effective in many, but not all cases. Drug therapy may be used to treat the symptoms, especially pain. At the start of the therapy, symptoms usually increase, followed by relief of pain 2 to 3 weeks. Common drugs include topical cream, capsaicin, tricyclic and antidepressant, amitriptyline, selective serotonin, and norepinephrine reuptake inhibitors, duloxetine, and anti-seizure drugs, gabapentin. Capsaicin is a moderately effective topical cream made from chili peppers. It depletes the accumulation of pain-mediating chemicals in the peripheral sensory neurons. The cream is applied 3 to 4 times a day. The tricyclic antidepressants are moderately effective in treating DM-related neuropathy. They inhibit the reuptake of norepinephrine and serotonin, which are neurotransmitters thought to play a role in pain transmission. We think duloxetine relieves pain by increasing the levels of serotonin and norepinephrine, and this improves the body's ability to regulate pain. The anti-seizure drugs decrease the release of neurotransmitters that transmit pain. Then we look at autonomic neuropathy. It can affect nearly all body systems and lead to hypoglycemic unawareness, bowel incontinence, and diarrhea and urinary retention. Gastroparesis, which is delayed gastric emptying, is a complication of autonomic neuropathy that can cause anorexia, nausea, vomiting, gastroesophageal reflux, and persistent feeling of fullness. Gastroparesis can trigger hypoglycemia by delaying food absorption. Cardiovascular problems from autonomic neuropathy include postural hypertension, resting tachycardia, and painless MI. Assess for postural hypertension to determine if the patient is at risk for falls. Teaching the patient with postural hypertension to change from lying or sitting position slowly. Diabetes mellitus can affect sexual function, Erectile dysfunction in men with DM is common. It is often the first manifestation of autonomic neuropathy. ED is associated with other factors, including vascular disease, high glucose levels, endocrine problems, psychogenic factors, and other drugs. Decreased libido is a problem for some women with diabetes mellitus. Candida and nonspecific vaginitis are common. ED and sexual problems require sensitive counseling for both the patient and the patient's partner. Look at chapter 59 for reproductive. We'll deal a little bit with this. A neurogenic bladder may develop as the sensation in the inner bladder wall decreases, causing urinary retention. A patient with retention has infrequent voiding. Difficulty voiding and a weak stream of urine. Emptying the bladder every 3 hours in a sitting position helps prevent stasis and infection. Tightening the abdominal muscles during voiding and using Credé maneuver, mild massage downward over the lower abdomen and bladder may help complete bladder emptying. Cholinergic agonist drugs such as uracil, bethanol may be used. The patient may need to learn self-catheterization. We talk about complications, the feet and lower extremities. People with diabetes mellitus are at high risk for foot ulcerations and lower extremity amputations. The development of diabetes-related foot complications can be the result of a combination of microvascular and microvascular diseases that place the patient at risk for injury and serious infection. Sensory neuropathy and peripheral artery disease are risk factors for foot complications. Clotting abnormalities, impaired immune function, and autonomic neuropathy have a role. Smoking has a negative effect on lower extremities, blood vessels, and increase the risk for amputation. Sensory neuropathy is a major risk factor for lower extremity amputation in people with diabetes mellitus. Loss of protective sensation, LOPS, often prevents the patient from being aware that a foot injury has occurred. And we get improper footwear. As we look at this picture here, necrotic toe before and after amputation. Improper footwear and injury from stepping on foreign objects while barefoot are common cause of undetected foot injury in the person with LOPS, because the primary risk factor for lower extremity amputation is LOPS. Annual screening with monofilament testing is important. I was just going over the information here on slide 172. Sensory neuropathy may cause loss of protective sensation, LOPS, and that prevents awareness that an injury has occurred, and then that loss of awareness becomes a major risk factor for amputation. Also, peripheral artery disease, PAD, increases the risk for amputation by reducing blood flow to the lower extremity. With decreased blood flow, oxygen, white blood cells, and vital nutrients are not available to the tissue. Wounds take longer to heal, and the risk for infection increases. Signs of PAD include intermittent claudication, pain at rest, cold feet, loss of hair, delayed capillary refill, and dependent rubor. That is when you put the feet are down, they turn red. PAD is diagnosed by history, ankle brachial index, and angiography. And management includes reducing risk factor, especially smoking, and managing cholesterol and hypertension. A patient can be educated on the fact of bypass or graft surgery being the answer for PAD. If the patient has LOPS or PAD, aggressive measures must be taken to teach the patient how to prevent foot ulcers. These measures include choosing proper footwear, protective shoes, teach the patient to carefully avoid injury to the foot, practice diligent care and nail care, inspect the foot thoroughly each day, and treat small problems promptly. Guidelines for patient teachings are listed in Table 53.23. Proper care foot ulcers is critical for wound healing. Several forms of treatment can be used. Casting can redistribute the weight on the plantar surface of the foot. Wound care for the ulcer can include debridement, dressings, advanced healing products, vacuum-assisted closure, ultrasound, hyperbaric oxygen, and grafting. Neuropathic arthropathy or Charcot's foot results in ankle and foot changes that lead to joint problems and foot drop. Of course, these changes occur gradually, and they do promote an abnormal distribution of weight over the foot. We're going on to skin complications. Up to 2/3 of the persons with diabetes mellitus develop skin problems. The diabetes mellitus related dermopathy, the most common skin lesion, is characterized by red brownish round or oval patches. They initially are scaly, then they flatten out and become indented. The lesions appear most often on the shins, but can occur on the front of the thighs, the forearm, and the side of the foot, scalp, and the trunk. Acanthosis nigricans is a manifestation of insulin resistance. It can appear as a velvety light brown to black skin thickening. Mainly on flexures, axilla, and the neck. Necrobiosis lipodica diabeticorum usually appears as a red-yellow lesion with atrophic skin that becomes shiny and transparent, revealing tiny blood vessels on the surface. This condition is uncommon. It occurs most often in young women. It may appear before other signs and symptoms of diabetes mellitus. Because thin skin is prone to injury, special care must be taken to protect the affected areas from injuries and ulcerations. Look at, as the slide says, the chart. You see a picture, necrobiosis lipodica diabeticorum. Let's look at infection. A person with diabetes mellitus is more susceptible to infections because of a defect in mobilization of WBCs and impaired phagocytosis by neutrophils and monocytes. Recurrent or persistent infections such as Candida albicans, boils, and furuncles in the undiagnosed patient often lead to healthcare provider to suspect diabetes. Loss of sensation, neuropathy may delay the detection of an infection. Persistent glycosuria, sugar in the urine, may predispose people to bladder infection, especially those with neurogenic bladders. Decreased circulation resulting from angiopathy can prevent or delay immune response. Antibiotic therapy has prevented infection from being a major cause of death in patients with diabetes mellitus. The treatment of infections must be prompt and vigorous. Teach patients to prevent manifestations by practicing good hygiene, avoiding exposure to persons who have communicable illnesses, and get an annual influenza vaccine and pneumococcal vaccine. When we talk about the psychological considerations, people with diabetes mellitus have high rates of distress, anxiety, and eating disorders. Depression and distress contribute to diminished diabetes mellitus self-care, feelings of helplessness related to chronic illness, and poor outcomes. Distress encompasses the stress, fear, and burden of living with and managing a demanding chronic disease. Assess patients for manifestation of depression and/or diabetes mellitus distress. Disordered eating behaviors can occur in people with diabetes type 1 and 2. DEBs include anorexia, bulimia, binge eating, excessive caloric restriction, intensive exercising. Adolescents, girls with diabetes are more than twice as likely to develop DEB than those who do not have diabetes. Patients may intentionally decrease their dose of insulin or omit the dose. This is called diabulimia. It leads to weight loss, hyperglycemia, and glycosuria because the food ingested cannot be used for energy without adequate insulin. Insulin omission and DEBs can have serious consequences, including retinopathy, neuropathy, lipid abnormalities, DKA, and death. Alrighty, talked about DEB. This is slide 178. The disordered eating behaviors, anorexia, bulimia, binge, excessive calorie restriction, intense exercise. Women are more prone, especially adolescents. They may decrease insulin, diabulimia, causing weight loss, hyperglycemia, glycosuria, but there are many serious consequences, as I said in the previous slide. Open communication is important for early identification and mental health referral. Let's look at the gerontological considerations as we're getting ready to end this recording. Diabetes mellitus is present in more than 25% of persons over 65 years of age. This age group is the fastest growing segment of the population that's developing diabetes. Older people with diabetes have higher rates of premature death, functional disability, and coexisting illnesses such as hypertension and stroke than those without diabetes. The prevalence of diabetes increases with age. A major reason for this is that aging process is associated with a reduction of B cell function, decreased insulin sensitivity, and altered carbohydrate metabolism. Aging is associated with conditions that are more likely to be treated with drugs that impair insulin action, like corticosteroids and antihypertensives and phenothiazine. Undiagnosed and untreated diabetes mellitus is more common in older adults. This in part occurs because manifestation of diabetes mellitus, such as low energy levels, dizziness, confusion, and chronic UTIs, are wrongly attributed to normal aging-related changes. So they're not investigated as a health issue because it is felt like this just happens with aging. In the gerontological population, glycemic control can be very challenging because there is a higher rate of hypoglycemic unawareness, which we have discussed previously, and there's functional limitations. They have comorbid medical conditions. There is at times in many cognitive decline. So the meal planning and exercise, the response to drugs can be altered because of all of these factors. And the teaching, which the nurse has to realize, must be adapted to meet the needs of the patient. Patient education issues include those related to altered vision, mobility, cognitive status, and functional ability. Plan your teaching on the basis, again, of the individual need. Use a slower pace with simple printed and audio materials in patients with cognitive and functional limitation. And always include the family and the caregivers in the teaching. Consider the patient's financial and social situation and the effect of multiple drugs, eating habits, and quality of life issues.